Hi everyone, good evening and welcome to all of you on behalf of RCVS Knowledge. I'm Amanda Bogue, I'm Chair of Trustees of RCVS Knowledge, and so it falls to me to be the great pleasure to get this session going. RCVS Knowledge is, as many of you will know, the independent charitable partner of RCVS, and our mission is to advance the quality of veterinary care for the benefits of animals, public and society. Over the last few years, we've had huge developments in our quality improvement education initiatives and evidence-based education and support. But the launch tonight of our Cruciate Registry represents a really important and potentially transformational next step in this journey for our profession. I know I'm identified in our profession clinically as an emergency critical care specialist, but it's a little known fact that I actually did the Orthopaedics elective as a student at Cambridge and scrubbed into one of the first TPLOs to be done in the UK back in 1998. I wrote one of my case reports on that dog, Ellie Drew. She was a big newfie, but I think since that time, probably my knowledge and understanding of cruciate disease has probably only deteriorated. So I know I certainly am really looking forward to the fantastic lineup of speakers we have this evening. For those of you wanting to share your attendance, then please use the hashtag Canine Cruciate Registry. And on that note, I'd like to hand you over to our chair for the evening, John Innes. John will need very few introductions, particularly in orthopaedic circles, an incredibly experienced clinician and mentor, formerly of Liverpool Vet School and currently Chief Veterinary Officer of CVS and Chair of the RCVS Fellowship Board. So on that note, I'll hand you over to John and look forward to a great evening.
Thank you, Amanda, for that kind introduction. And thank you for representing RCVS Knowledge as the Chair of Trustees. Very grateful for the support of RCVS Knowledge for this initiative. So it's my job this evening just to chair proceedings, and time is relatively short given that we've got a fully packed programme for you with some really excellent speakers who have particular expertise not only in canine cruciate ligament rupture and ligament disease, but we've also got a representative from human medicine to tell us all about their experiences with ligament registries in human medicine. So we've got a really good programme this evening. So I'd like to introduce the first speaker, and that is my colleague Mark Morton. Mark has been the driving force behind this registry, and he's been working on this concept with RCVS Knowledge for several years now. So well done to all of the team at RCVS Knowledge and all of the team that have supported Mark in bringing the registry to this point. It's a very exciting concept, and we want as many people to get involved as possible. So without further ado, Mark is an RCVS specialist in orthopaedics, and I've known Mark since he was a student. He's had a lifelong interest in orthopaedics in terms of his career, and Mark will introduce us to the registry in this first session. Over to you, Mark.
Thanks very much, John. And Amanda, thanks for introducing the event this evening. I'm just going to share my screen. And I presume that somebody will tell me in the chat here if it hasn't worked and you can't all see it. As you know, John's agreed to chair the event for us tonight. This is just a brief overview of the proceedings for the evening. I'm going to introduce you to the Canine Cruciate Registry, a bit behind the concept, how it works, why we think it needs it. Delighted to welcome some great speakers as well who've agreed to speak to us tonight. Stanley Kim from the University of Florida is going to share some interesting work about the stability of the stifle joint before and after cruciate surgery. I'll pop on again and tell you a little bit more about the ins and outs and show you how the registry portal itself works. And then again, delighted to welcome Professor Duncan Lascelles, who's going to talk about how we can assess outcomes in dogs. And as John said, Mike McNicholas, who's a human orthopaedic surgeon and on the steering group of the Human Cruciate Registry, the National Ligament Registry, agreed to join us and share their experiences, and I'm sure that'll be an interesting talk for us all. So without further ado, we'll move on to my first talk. So from a conflict of interest point of view, I've got nothing to declare. So first off, a question really, bit of a rhetorical question, but what would you do if your dog ruptured its cruciate ligament? If you decided that your dog needed to have surgery, who would you get to do it? How likely would that surgery be to go well, and what problems might occur with it? Do you know how well your dog will do in the long term? Will it get back to normal? These are questions that we all think we might know the answer to, but the registry aims to provide us with more answers to all those questions. As many of you will know, the cruciate ligament sits in the knee joint, or the stifle joint as we call it in the dog. Its job is to stop the tibia moving forwards and backwards. In most dogs, cruciate issues are a degenerative problem rather than the sort of traumatic type injury we see in people. Cruciate ruptures are an endemic condition in dogs with an overall prevalence thought to be about 0.5%. As an orthopaedic surgeon, it makes up a good half or 2/3 of my work, but it's a really common presentation for most small animal vets to see. About 2/3 of cruciates are managed surgically in dogs, with about 20% of those cases referred. Just to sort of highlight the prevalence, I don't know how many of you be familiar with Vet Compass, but it's a great surveillance tool run out of the Royal Vet College, where from practice management systems, they analyse records to see how common conditions are. You can see per 1,000 dogs, cruciate disease is about 12.5 cases. But if you look at all the other things in there, lameness, osteoarthritis, arthritis, stiffness, a proportion of all those cases, I'm sure, will have cruciate disease underlying it. Cruciate issues in dogs is probably one of the most studied conditions in orthopaedics, if not in veterinary medicine in general. There's 2 relatively recent review articles that showed there's increasing evidence for tibial plateau leveling osteotomy, giving better outcomes. But as important as that was both of these studies highlighting the lack of evidence to evaluate the techniques that we commonly perform. Treating cruciates can be controversial. We could have a whole weekend orthopaedic meeting discussing these issues. What's the role of conservative management? What technique would you use if you're going to perform surgery on a dog? We will even argue amongst ourselves, orthopaedic surgeons, about how the stifle actually functions. Different procedures will require different skill levels, different equipment requirements that may or may not be available. There's economic factors. Not all cases will be able to be referred to an orthopaedic specialist in a referral hospital for an osteotomy, for example. Some procedures are viewed as more invasive than others. And patient factors. What do you do if dogs have comorbidities that may mean surgery is not appropriate? Finally, of course, there's the old issue of orthopaedic surgeons themselves. We've all got individual techniques of choice. I'm sure it's the same in the human world, and it takes a lot to sway us from our preferred technique. Some of those views are based on evidence, and certainly some are based on anecdote as well. What we need is more data around cruciates. So what will help get this data? Well, certainly better evidence. The idea of having meta-analyses that review lots of different previously published studies are great, but for the outcome of a meta-analysis to be really strong, the quality of the evidence below that's involved in that analysis needs to be good as well. Better data or better evidence is not easy to get. Performing clinical trials and studies is hard. Surgeons will have a preference or a bias, and it's difficult to get surgeons to do lots of different procedures and see what their outcomes are. Ideally, we'd run sort of multi-center randomized trials, but they're really, really difficult to do and difficult to get large numbers of people involved with. How we assess outcomes can certainly be improved, so better or more outcome measures, and we'll talk about that a little bit later on as well, and I know Duncan will tell us more about that. Research is changing. There's a great editorial by Rachel Dean in the Vet Record a couple of years ago now. But end users, so in our case vets, must be involved in deciding what research we need. The results of research must be applicable to them, to their practice, their patients and their clients. It's really well known in medical research that that clinical research is difficult to replicate in real life. And it's certainly true in veterinary medicine as well, that a lot of the research that's performed is done in a setting that's very, very different to day-to-day practice, where there's a broad population of patients that don't quite fit into a strict selection criteria for a study. Studies have also got to be accessible. It's really difficult to get studies published. There's lots of hoops to jump through. So, you know, people do work and then can't get it published. And also lots of research is published in sort of special interest journals, if you will, so orthopaedic journals that might not be read by your average clinician, let alone non-veterinary professionals. So we need to look at how we share that information as well. Our solution to this problem, for cruciates at least, is the RCVS Knowledge Canine Cruciate Registry. And I'm so pleased that we finally got to this point where we can launch it this evening and welcome you all to get involved. I'm really grateful to the support of RCVS Knowledge. I approached them over 3 years ago now, presented this concept to the Quality Improvement Board, and they were very keen to get involved. Thanks so much to the whole team at RCVS Knowledge, particularly Ashley, who I've worked a lot with over the past 3 years to get this off the ground. She sort of managed this project and kept kicking it along, and it's certainly a much better project than I envisaged for her involvement. Thanks to the rest of the team, Amelia, Georgia, Emily, Sarah, Chris, the Board of Trustees. You know, it's really with your backing that we've got to where we are today. It's really good that this project is part of a bigger concept as well. So the vet audit project is something that RCVS Knowledge is spending a lot of time and effort on. And I'd encourage you to go and look at the website and see what else you can get involved with. Our registry is run by Amplitude Clinical Outcomes, who are a global leader in human registries. The project's endorsed by the British Veterinary Orthopaedic Association. We have ethical approval from the RCVS Ethics Review Panel, and their input was valuable as well. That's certainly, you know, their thoughts and careful questioning helped develop this project. We're grateful to Elanco and ACVS for allowing us to use load and the Canine Orthopaedic Index as outcome measures. Before we dive into the project, I thought we'd just sort of take a step back and sort of look at what a registry is. So registries aim to improve outcomes via feedback to hospitals, surgeons. They detect failures with procedures and devices, and they identify prognostic factors associated with both good and poor outcomes. And they do that by recording information about the health of patients and the care or the surgery that they have over a period of time. Examples on the human side would be the National Joint Registry, which is mandatory for all joint replacement surgeries in the UK, the National Ligament Registry, the British Spine Registry, and of course, I know many of you will be familiar with our own BVOA Canine Total Hip Registry. So this is a really good example of a registry in the vet world. It was founded by our chair today, John Innes, back in 2008. The aim of that registry was to analyse outcomes of hip replacements in the UK in dogs. So far, there's about 1,500 cases on there. Ethnic Homiford has taken over running the registry now. There's been international expansion. You know, go to their website and have a look at the work they're doing as well. But it has generated really useful data for us as orthopaedic surgeons. It's shown different complication rates with different procedures and comparing them. And that's been useful. That's simply data that we didn't have before. So how does the Canine Cruciate Registry actually work in reality? Well, it's open to any vet in the UK performing any surgical technique. It's all digital and online based. There's no reason why we can't expand further afield. Once we're up and running, you know, cruciate surgery is pretty similar the world over. The major complicating factor there will be sort of data protection laws, etc. But we have had interest from further afield as well, so watch this space. I'm pleased to say that the registry is free of charge to both vets and owners. This project is all about the outcome, not about the income. Just to show you how we structured this project, and we don't need to dwell on this too long, but our aim was to get a consensus opinion to build this registry with expert input. It was really important to us to get some owner input as well. Zoe Belshaw's work in the vet record, highlighting sort of owner experience, has really opened my eyes, certainly to you know, the value of taking on board how owners view treatment of their dogs. We sit under the Quality Improvement Board at RCVS Knowledge. We have a steering group made up of some orthopaedic specialists, some GP vets, an epidemiologist, some board members from RCVS Knowledge, and a lay member. And we also have a clinical advisory board made up of some orthopaedic surgeons, both specialists and vets in practice with a particular interest in orthopaedics, as well as an epidemiologist. And the clinical advisory board was there really just to build the data fields to start off with. Thanks to all my colleagues here who've also put a lot of time into this project and put in or shared their expertise with us in generating the data set. So there's the advisory group. I won't go through them all, but I'm really grateful for you agreeing to get involved and the time you've given us. Long term, as I say, this will be managed by the steering group. And we'll look at how the registry runs, we'll look at the data it generates, we'll deal with research requests and any other sort of problems, and also look at how the registry grows and develops in the future. From a data protection point of view, the registry is completely anonymous, so you can see your own results, but nobody else can see those. It's GDPR compliant, and the consent is required from both owners and veterinary surgeons who are participating. So a brief sort of overview of the workflow of the registry. Once a dog's diagnosed with a cruciate rupture and surgery is advised, the owner's enrolled onto the online portal. They complete a baseline questionnaire about their dog's lameness. The surgeon then completes a surgical report form detailing all the information about the surgery, and that's done at the time of surgery or shortly after. The owner is then contacted on a regular basis to complete further questionnaires and report any complications. Surgeons can review information about their own patients in real time and monitor their progress. Anonymised results are also available online and will be published in an annual report. And when we have enough cases, we'll look to submit peer-reviewed or publications for peer review. We'll have a look at the registry website in the talk later on, but it's really good, and I think it'll be a useful resource to lots of us, both owners and vets. We'll use the website to show real-time results. You'll be able to see outcomes on there, complication rates and demographics of patients. You can use the registry portal for individual clinical audit or for a case log. There's resources on the website for both owners and surgeons. That's how-to guides about how to use the registry, but also educational material for owners that they can review in their own time, or you can use with them at the time of consultation to discuss cruciate ruptures or particular procedures that you may want to do. All the administration for the registry portal is also linked from the website, so that's how you'd get into it. From a publication point of view, as we say, we'll publish an annual report, and we hope to get some publications out of this. We'd welcome external research projects going forwards. You know, if you have a particular idea of something you'd like to look at with cruciate surgery, you know, we would welcome approaches to add extra questions for a period of time, or whatever that may be, or requests to access data. We'll also publish our results at, or give an annual update at one of the BVOA meetings every year. So how we assess outcomes is probably the trickiest bit of this project. I know Duncan is here to talk about this later on, and he'll go into that in a lot more detail. But ideally, to assess lameness in a dog before or after surgery, we would use objective data. And when we say that, we would be talking about something like a force plate, where a dog walks over a platform and it can show how much weight they're putting through a leg. and you would repeat that after surgery, for example, and hopefully show an improvement in limb use following a particular intervention. That is not straightforward to do across lots and lots of cases. It takes lots of time, it's really expensive to do, and it's just simply not viable. Although owner and vet assessment is inherently subjective, that doesn't mean that we can't use it. If you use appropriate methodology, subjective answers can be reliably quantified using a clinical metrology instrument or a questionnaire. In clinical metrology instruments, the same questions are asked to each patient and repeated over a period of time. In people, these are called patient-reported outcome measures, and there's hundreds of different outcome measures in orthopaedics for different conditions. In the veterinary world, we have LOAD, the Liverpool Osteoarthritis in Dogs questionnaire. We have the Canine Orthopaedic Index. We have various other outcome measures, the Canine Brief Pain Index, for example. We would call them client-reported outcome measures because obviously we struggle to get our patients to tick boxes on a questionnaire. LOAD, or the Liverpool Osteoarthritis in Dogs questionnaire, is a validated outcome measure with correlation to force plate data. LOAD and the Canine Brief Pain Index are probably the most evaluated outcome measures that we have in orthopaedics. Some of these instruments that we've just talked about are designed for assessing pain, and that's probably not the most appropriate thing to assess in cruciate patients, just looking about how comfortable they are. Things like mobility and exercise are probably more important. When you design these questionnaires, one of the things that you do is assess something called construct validity. Ben Walton's work on LOAD showed that the LOAD questionnaire is influenced by 3 factors. 2 of the main ones being demeanor and activity, and lameness and stiffness, and both of those are probably really appropriate things to look at for cruciate patients. The Canine Brief Pain Index was shown to just assess pain alone. There were potential issues with assessing outcomes like this. Mike Consumer showed a caregiver placebo effect of up to 40% in osteoarthritic patients. Things we might look at going forwards. Well, recently CMI data has been used to define success or failure, and that might be appropriate for some cruciate surgeries. We don't know. One of the other things that would be really interesting is to look at the minimally clinical important difference, which essentially is we will look at what change you need in LOAD score and COI score over a period of time for owners to report that it's made a big difference to their dogs. And that's something that's not been done really in veterinary orthopaedics. To define our outcomes and look at complications, we'll use the definition that's defined by the consensus group. We'll also use that for timescales and the severity of complications, as well as looking at the sort of outcomes of patients using our questionnaires. There will be a vet assessed outcome in there as well. There will be an owner satisfaction score and a friends and family type thing as well. And whilst they might not contribute to the research or the data that we publish, certainly they'll be of added value to all the surgeons who are participating. From a reporting point of view, the Amplitude platform is great for displaying data. There'll be a standard dashboard of results from across the registry. We simply don't have enough data from the time we've been using it in a trial to configure that properly yet, but over the next couple of months that will be visible when you log on and click into the results section. There's a report writer, so you can build your own reports from your data set and look at whatever you want. You can export that to Excel. You can make pivot tables from that. The registry produces these really nice funnel plots where you can see where you compare to your peers anonymously. So how your patients are doing compared to everyone else's. You can also use this thing called a score comparator, where it's a little bit similar to the funnel plot, but the graph plots patients' baseline score and their 6-month score and shows whether they're improving or not. You can hover over any outliers and get straight to the patient record to see what might be going on. You can also use the reporting software to help with credentials for advanced practitioner status, specialist status, or revalidation for diplomat status as well, if you need to log how many particular types of cruciate surgery you've performed. What are the benefits of this project? Well, for patients and owners, the number one is patient safety. We want to be able to ensure best outcomes for all the patients we operate on and minimize complications. It may be that we can individualize treatment, that some procedures are better for some dogs than others. Hopefully, analysing our results will provide some protection against novel procedures. So the registry could be used to evaluate a new technique or a new implant. We would welcome approaches from that point of view, but we will require ethical approval for any studies that want to use the registry to evaluate their techniques. On a day-to-day basis, monitoring how your patients are doing long-term, the registry will be great for that. And the Hawthorne effect as well is a phenomenon where people modify their behaviour subconsciously when they know they're being observed. From a veterinary surgeon point of view, well, the registry will help with owner guidance, knowing how well dogs do and what complication rates are of particular procedures. From a clinical audit point of view, it'll be really, really easy to do personal clinical audit. I know how difficult that is to do with the practice management system we currently use. The less effort it takes, the more likely people are to be able to do that. From the point of view of reporting complications, one of the things that's often levelled at studies is if complications have been missed, but this way with the registry, owners can directly report if there's a problem. So, for example, if a case is referred, the owner won't miss that if the complication was treated back by their primary care vet. And also, as we talked about earlier on, the registry can be used for research projects that we probably haven't even thought about yet. From the profession as a whole, what we want to do is improve the evidence base. This will help us guide treatment decisions for all our patients. It'll be really good to have an accurate real-world complication rate for each of these procedures rather than the rates we use at the moment, which come from a small number of cases in a well-defined and controlled study. And it might be as well that we can highlight early on particular problems with novel procedures that can often be missed if there's several surgeons across the country having a problem. They think it's just them that's having a bad day or a bad week or a bad month. But this should highlight any emerging trends on that front quite quickly. The challenges with this project, well, of course, we're all short of time. We hope that the guides we've developed and put on the registry website will help people be able to use the registry quickly with minimal effort. From an engagement point of view, this project relies on veterinary surgeons and owners getting involved to generate data. And I would encourage anybody who's interested to sign up and get going. And we'll help as much as we can with engagement of owners with the resources that we have on the website. The outcome measures we've chosen to use might not be perfect. They're probably the best we have at the moment. We've spent a lot of time thinking about that. There's no reason we can't add more in the future. And certainly we will lose cases. So, we won't get people completing all the questionnaires for the rest of a dog's life, for example. In human registries, 30% is good from a point of view of how many patients continue submitting data long term. So I hope we can do a little bit better than that. One of the things we've learned from the human side is encouraging people. One of the good ways to encourage people to use a registry is by letting them know that you can't phone them up every 6 weeks or 6 months to see how their dog's doing. But if they complete the scores, you will monitor those scores. And if there is a problem, if their dog is suddenly not doing very well, you will know that. So it brings them into or gets them involved in the monitoring of their pet's progress over time. There are a few sort of controversies or questions that people have asked as we've gone through this project. So this first one is can you use this to evaluate conservative management? Well, this is a surgical registry in the first instance, comparing different surgical techniques. That's not to say there's not a role for conservative management with cruciate ruptures in dogs, but some of the issues are issues around diagnosis. How can you be sure it was a cruciate rupture? Conservative management's really difficult to standardise compared to a surgery. So how long does a dog rest for? Is all rest the same, etc., etc. And there probably is a question to answer between conservative and surgical management. You know, those studies haven't been done for a number of years now, but a registry is not the way to answer that question. So there is some research gap there, but you wouldn't really use a registry to answer that question. I hope people will want to get involved. This project is open to all. If you're not performing cruciate surgery, I still think this is an interesting project, because if you're a small animal vet, you'll still be seeing dogs with cruciate ruptures, and you need to know what the best treatment option is to recommend to your clients. From a publicity point of view, we'll try and ensure that data is used appropriately. No problems at all with people sort of publishing their complication rates, etc. That's a really good thing to do, but that needs to be done in an appropriate way. So the sort of motives of the project have been questions at times. You know, is this just a project to develop more work for specialists that all dogs should have osteotomies? That certainly isn't the case. The registry is open to all vets. We've involved vets from across the profession in the broad steering and advisory groups that we've got. The outcome of some of this data might be that if you go and see a specialist in orthopaedics and have a particular procedure performed, that the outcome is better. That would be valid evidence-based veterinary medicine. But that's not the most interesting thing that might come from this. What do you do if that's not an option for your patient or your pet? You know, what's the next best outcome? So there's a much wider debate to be had here. From an engagement point of view, we're pleased that the British Veterinary Orthopaedic Association have endorsed this project. Going forwards, we hope to be able to develop a sort of affiliation scheme so vets can proudly say that they contribute to the Canine Cruciate Registry. That may be by, you might be able to say I've submitted 100 cases or whatever it may be, but that's something that we're looking into. I hope this will become desirable for surgeons and owners, that you will want to take part, and owners will ask, do you contribute to the Canine Cruciate Registry? It may be that this, participation in a registry project can give you points for credentials, whether that's diplomat or specialist status or advanced practitioner status. And it may be that as a practice being involved in a registry project can help with your practice standard scheme, accreditation, etc. And they're all things that we'll look at going forwards. We've engaged with all the major employer groups as well to try and get as many vets as we can involved in this project. So that's a brief introduction to the project. I hope you'll stay tuned for part 2 later, where we'll have a little bit of a look at the registry portal and the website and things, and we'll show you how you can register to get involved and put cases on, etc., etc. Thanks very much. If there's any questions, we've probably got a little bit of time, have we? Or maybe we need to move swiftly on.
Thank you, Mark. It's obvious from that presentation how much work has gone into this. Really appreciate that. And 3 years you've been working with the team at RCVS Knowledge, and I know everyone's put a huge amount of work into it. So well done. That takes a lot of determination to get to this point. Just to remind people that are listening, we have the Q&A function, which you can use to pose questions to any of the speakers tonight, and I will use that function to ask those questions on your behalf. So please use that function. You can do that anytime. We'll have a little slot after each talk to allow for questions, and we'll also then have a wrap up at the end where we can ask questions from to any of the speakers. So please feel free to put a question on there, and I will voice that question for you. Mark, I suppose just one question, and we're sort of going to run too short on time. What do you think success would look like? If in a year's time you look back and over the first year of the registry, what's your sort of target in terms of participation?
We've talked about this a lot, actually, and the honest answer is we don't know. We're very optimistic that people will want to get involved. It's been well received every time we've talked about it or presented it at various places. I think for me, a sort of group of vets from across the profession submitting cases on a regular basis, whether that's 40, 50, 60, 2,000 vets, but people getting involved and wanting to be involved, and as being able to show the benefits. So being able to demonstrate there's value in the data, I think.
Great, thank you. Now, Mark, there is one question that's come in here, which I might ask you now, but you may want to think about it and come back and answer it in your second talk, because I know you're talking about the mechanics of the registry in your second talk. So the question is, are there any issues if we were to register as a small animal practice, but we had a referral orthopaedic surgeon coming in to do the surgeries in-house? How would, I think how would he navigate then?
Yeah, well, we can touch on that a little bit later, but it would be the surgeon that registered. So rather than a practice, you would register as an individual surgeon. So he would or she would have their own cases, if that makes sense, and it would be under their name rather than the practice. Obviously it's a discussion to be had whether they sort of share their results, but I'm sure most vets going in would be happy to share their results, etc., etc. There wouldn't be many reasons why you wouldn't want to do that. So,
okay, great. Well, we have other questions are coming in, but in the interest of time at the moment, Mark, we'll park those. Hopefully, come back to them at the end. Please keep putting your questions in the Q&A. But thank you, Mark, and we'll come back to you later, I'm sure. And now it's my pleasure to go across the virtual pond. We've got Dr. Stanley Kim speaking to us next, and Dr. Kim is Associate Professor at University of Florida, and he's done some really interesting work about looking at clinical outcomes in cruciate surgery and the stability of the knee joint or the canine stifle joint. So really delighted to have you here, Dr. Kim. Thank you very much for giving up your time to speak to us, and we're all looking forward to what you have to say. Thank you.
Okay, is this coming through okay? Can you all hear me?
That's good.
Okay, great. Well, thank you all for attending, and pleasure to be here. Really honored to be invited to this Canine Cruciate Registry launch. As Dr. Innes had mentioned, our group has a special interest in cranial cruciate ligament rupture, and I was asked to share our perspective on the disease process and give some perspective on how we use this information and how it relates to the really huge potential of this registry. So the title of my talk is The Dichotomy Between Clinical Outcomes and Joint Stability with Cranial Cruciate Ligament Surgery. So I do have to declare that I am a consultant for Arthrex Vet Systems, and they do make products for treating cranial cruciate ligament rupture. So our bottom line interest, research interest, is what are we really doing when we take a scalpel to the knee of dogs with cranial cruciate ligament rupture? That's our ultimate mission, to understand what we're really truly accomplishing here. And I'll start by using this analogy. I know there are several pet owners and a lot of GPs out there in the virtual audience. And so, say you get this very common scenario of a dog that has gastrointestinal signs, vomiting, diarrhea, what have you, and you prescribe a course of a gentle diet, certain medications, and give it some time to do its thing. Lo and behold, the dog recovers and we're all giving ourselves a big pat on the back. Then we ask ourselves, say retrospectively, what was the main treatment that contributed most to the overall success of the case? And there may be some clinicians out there that said, well, it was this pill. It was this pill. I mean, take your pick, metronidazole, another antibiotic, antidiarrheal, whatever it is. And totally convince ourselves that without this medication, the treatment would not have worked as well. So what is this pill from our perspective? This pill is surgery. Okay, this pill more specifically is providing stability to the joint, thereby improving the comfort of the animal, right? Rationale being, of course, cranial cruciate ligament rupture. The reason why they are not doing well, the reason why they are limping is because of joint instability. So logically, let's stabilize the joint. Of course, there are many stabilization options out there. Lateral suture stabilization here on our left is depicted. The most common procedure that is performed across the world really now is TPLO in the middle. And then the TTA there depicted on the right would be the most common. So, and of course, all of these are aiming to impart adequate joint stability. So we know, for instance, that the TPLO works, okay? All these procedures work in that they produce pretty good success from the perspective of the owner, from the perspective of the clinician that is evaluating the animal during a clinical examination. And I've listed a few of these actually quite strong studies that support this statement that TPLO works. Likewise, lateral suture works. Likewise, TTA works. And some of the strongest lateral suture studies, which has kind of fallen out of favor, as you may or may not know, if you look at some of the older literature in particular, their bottom line statements from studies study designs that were not really all that dissimilar to TPLO studies are very, very similar to TPLO, right? So for instance here, lateral sutures, treated stifles were not significantly different from normal on objective analysis, forced platform gait analysis. We have very high owner satisfaction rates, 90%. You know, we have bottom line statements, conclusions, such as all dogs regaining acceptable function. Now, during my residency, one of my mentors, Dr. Dan Lewis, really opened my eyes to this condition and sparked a lot of curiosity in what we're doing with these treatments. And he told me during some of these routine cruciate surgery rechecks, right? Often we don't even give a second thought to them. Dog's doing well, off you go. Radiographs, everything's healed. But he told me to really carefully feel the position of the joint, right? As they're standing. Cranial cruciate ligament rupture will invariably result, complete cranial cruciate ligament rupture will invariably result in cranial displacement of the tibia while they're standing, okay? So if the procedure really worked, then this should be gone. The joint should be in normal alignment, right? And so here's an example of what we would actually commonly find in dogs that were perceived to be doing well by the owner and by us if you just watch them walk. And that is that they were still standing in subluxation. Here's a representative video. So what you can do is you put your thumb back on the fibella and then cup your hand around the tibia, index finger over the tibial tuberosity here. And you can appreciate that actually they're standing subluxated, because if you squeeze your hand, you can actually click it back into reduction. Okay, this is actually how I now diagnose complete cranial cruciate ligament tear. Not draw, not thrust. Check if they're standing in draw, right? So this is a dog after surgery. As I said, this was a common finding. So the question then is like, what are we doing to these animals here? Why are they getting better? And this initiated a pretty big line of research for me, right? Over the last dozen years or so. I mean, we have the theory of why it works. Slocum presented it beautifully for TPLO, Slobodan Tepic for TTA, for instance. And then early on, we've got some ex vivo supportive data showing that this theory has merit, right? You do the procedure in cruciate deficient stifles, they get better. And we, though, and having done ex vivo studies, that was the main focus of my master's, actually, ex vivo analysis of TPLO and TTA, had a good sense of really the major limitations of ex vivo studies. And we wanted to know, well, what's going on in real life? Okay, so I'm going to show some of our in vivo work, static studies with standing radiography, and then some of our in vivo work utilizing fluoroscopic analysis, so dynamic studies. So for our static studies here, we've published 2 papers, one on TPLO and one on TTA. They do use slightly different study designs, so it's hard to make accurate comparisons between the findings, but here is a summary of those findings. What we did is we took dogs clinically affected, clinical dogs with cranial cruciate ligament rupture that had a TPLO or TTA, and then at various time points after surgery, we would have the animal stand. This standing radiography was first described by Mike Konzemius from Minnesota, and do horizontal beam radiography, right? Try to get them standing as comfortable as possible. A cassette placed between the legs, and then get an image of the joint, radiographic image of the joint alignment. And what we would do is we'd measure the distance between the origin and the insertion of the cranial cruciate ligament, and clearly increases in this distance were indicative of subluxation or malalignment, persistent instability. And for TTA, this chart is representing TTA. We have this cruciate distance on the y-axis, and the left column is representative of this distance when the animals were non-weight bearing right after surgery, i.e. the routine post-operative radiograph. You can see that distance averaged around almost 26 millimeters. They were brought back for long-term follow-up at various time points. And you can see that the mean distance increased substantially by about 5 millimeters or so. There was some variation here between subjects, but overall, over 80% of dogs with TTA had some moderate degree of persistent cranial tibial subluxation. So here's some representative images. In one case, you can see the non-weight bearing radiograph on the left. What I want you to look at is here the position of the condyles, femoral condyles relative to the caudal tibial plateau here. That's a relatively normal alignment. And then during weight bearing, you can see that the femoral condyles are not slipped off the back of that tibia. Whereas in this case, we can see that there is cranial tibial subluxation, most obviously seen by the caudal displacement of the femoral condyles relative to the caudal aspect of the tibial plateau. Now, all of these dogs, I should state, were doing fine according to the owner and on our own gait assessment. So what about the TPLO? Here's a representative image of the amount of subluxation we see before surgery. You can see here substantial cranial tibial subluxation. And then in this same dog on 6-month follow-up, we can see that that joint has reduced nicely. Not all dogs did this though. So here, for instance, in this case, we can see that there is obvious persistent cranial tibial subluxation. It's like we did nothing for stability. Not all dogs did this, but overall, a third of dogs had some certain degree of persistent subluxation. This was really confusing to us in terms of, well, the same sort of confusion that was generated when I was asked to feel the joint alignment on these routine rechecks. So it really corroborated our impressions. So there was one peculiar finding that was with respect to meniscal status with TPLO and joint alignment. Okay, so again, here on the y-axis, we have this distance. Remember, increases in this distance are indicative of subluxation. We've got no load here. We have before surgery, they're obviously subluxated, and then we have 6 months after surgery. So if we follow the blue columns here, right, you can see that we have subluxation of over 5-6+ millimeters, I guess, increases in that distance rather. And then that returns actually to more normal levels where there is no significant difference from the unloaded state. Now, these blue columns represent dogs with actually an intact medial meniscus. For dogs with that required a hemimeniscectomy for a meniscal tear, on longer term follow-up at 6 months, they had persistent subluxation where it was significantly higher. The cruciate distance was significantly higher than no load, but it was still significantly lower than before surgery. So meniscal status appears to be playing a role here, which can make some sense too. We try to correlate, right, how well the dog is doing on forced platform gait analysis with the amount of joint subluxation, joint instability, and really couldn't identify any correlation between how subluxated they were on static radiographs and overall limb function. So this brings us to our next study. Maybe it's that, yeah, when you put them standing and you stick a radiographic cassette between the legs, that some of them, that's going to generate some awkward position and that's going to induce subluxation. Maybe it's that when they walk around or run, they are doing fine and the joint is in appropriate alignment, and perhaps that can explain why the dogs are doing so well. So that was the motive for this series of studies, where we walked these animals over a treadmill before and after surgery. And we did this for 2 procedures, TPLO and lateral suture stabilization. What we can really precisely define in 3 dimensions, the joint alignment with sub-millimeter accuracy. We do CT scans of each individual animal, do 3-dimensional reconstructions of their specific bones. Then we can take these models and superimpose them over the fluoroscopic images until they perfectly match. And then from the positions of these models, we can derive joint alignment in all 3 dimensions. And so here's a representative video cycles before surgery, before lateral suture, and then after lateral suture. So what we have here, similar to the charts that I've shown before, on the y-axis is the higher you go, the more cranial tibial translation you have. Okay, the lower you go, you have caudal tibial translation. So you can see in normal animals over a gait cycle, this is when they're standing and then when the leg is swinging, is that there's very little cranial to caudal motion, right, over a walking gait cycle. Before surgery, it explains very clearly why they're lame. We have 10 millimeters of subluxation, right, cranial tibial subluxation that predominantly occurs in the stance phase of gait, okay? So what would we expect after surgery? Well, we ideally would want to see these the line after surgery superimpose over this normal control, right? Well, here's lateral suture stabilization. It was not distinguishable from the preoperative state, okay? And obviously significantly higher, significantly more cranial tibial translation than the control population, which actually was an internal control. These were dogs with unilateral cranial cruciate ligament rupture. So our control group here is the contralateral normal leg. Internal control, pretty powerful way to analyze it. Okay, so what about TPLO here? TPLO was just as interesting in my opinion. Same curves here, so you can see no cranial tibial translation over a gait cycle. Well, in the normal stifle, when there's cruciate deficiency, massive subluxation, explains really clearly why they're lame. After TPLO at 6 months, actually, on average, they translated caudally. So they're walking around on average with about 3 millimeters of caudal tibial subluxation. Okay, so is this bad? Is this good? We don't really know. What we can say that it's not normal. But there was quite a bit of variation even within our study population. So we noticed that there were some dogs with persistent cranial tibial subluxation represented here in the yellow. You can see that it's still substantially lower than the red, right? But still about 3 millimeters or so of cranial tibial subluxation. And then this shear back into caudal tibial subluxation, right? So there's shear motion going on through here, through the stifle, in these dogs with what we're calling persistent subluxation. Then there are dogs that were not subluxated cranially, but the magnitude of caudal tibial subluxation was substantial. And this had some correlation here with tibial rotation, in that dogs with ACL, cranial cruciate ligament rupture, you have quite a lot of internal tibial rotation here. You can see what the normal pattern should be. And then those dogs with persistent subluxation here in the yellow had a lot of persistent internal tibial rotation, okay? So how do you interpret all of this, okay? Well, it's a little tricky to interpret. How do we interpret it in the context of all of these studies saying that there's, 90+% success rates, right? Clinical outcomes, reported clinical outcomes do not really, well, let's put it this way. The abnormal biomechanical findings that we've identified in our studies don't explain the clinical outcomes, right, that have been published. There are clearly other clinical factors at play here, right? It's multifactorial condition. What about meniscal status, OA, chronicity, owner perceptions? I mean, it's use of it's really multifactorial, right? So there are other clinical factors that we're really not accounting for. Nevertheless, the dichotomy between the clinical outcomes and the abnormal biomechanics that we have identified needs to be addressed, right? We really need to explain this, because ultimately this is what we're telling our owners. We stabilize the joint, your dog's going to get better. Our data would argue that's not really the case. I believe that we can get a better explanation for what's going on here by having a better understanding of the overall clinical outcomes. As Mark alluded to, our clinical outcomes that are currently published have major limitations. And that's what I think is the main reason why there's this disparity between these two features of cruciate disease. So what do we need here? In my opinion, we need much stronger clinical studies. So, you know, in the I guess last century, the study designs were really weak instruments, not validated, retrospective, small numbers. We are getting better though, you know, bigger studies, prospective studies, controlled comparative studies, and better instruments such as some of the ones that were already mentioned, like the load score. And beyond, what are we looking at? Well, we can take these instruments and get massive numbers. And that is what I'm most excited about this registry, is we need adequate numbers. We need properly powered studies here, even if it's from the perspective of the owner. And very, very importantly, what's going on long-term in these cases. And then from here, we can derive, you know, even bigger studies such as meta-analyses. So the better the study, the larger the numbers, the better the quality of the clinical outcomes. So I'd like to end by acknowledging some of my mentors and former residents and students listed here, particularly Dr. Potsy and Dan Lewis. And at this point, I'd like to thank you all for listening and happy to entertain any questions.
Kim, fantastic presentation. Thank you very much. Really elegant work. And I think it's really enlightening in terms of, you know, you're challenging the assumptions around the biomechanics of some of these osteotomies and finding things that we didn't expect, I guess, and the role of the meniscus actually becoming quite important there. Interesting in the context of you know, meniscal release, as it was called, to prevent late meniscal injury, and another controversial topic. So great research program. Just one question for me right now, and then we'll come back, I'm sure, at the end. But what's your next step? Where in your own research program, you've been very complimentary about the registry, but what's your next step in terms of your group's investigations?
Yeah, the next most logical step, which we've been asked quite a bit about, would be to investigate other techniques, other surgical procedures. There's been some pretty good work, very good work, I should say, from Dr. Peter Botcher's group in Europe, and where they've done similar types of studies for TTA. And that, combined with some of our research, as I've shown with static studies, have kind of dampened our enthusiasm a little bit for doing additional work with fluoroscopy. It's extremely labor-intensive work. They're expensive studies, difficult to fund, and so it's been a challenge to kind of continue down this line of work, to be honest. But we are investigating, about to commence a prospective study on using the internal brace, essentially a lateral suture stabilization combined with TPLO, to try to see if we can totally eliminate cranial tibial subluxation, because it appears to be associated with internal rotation. So that's our next kind of big study. I mean, I would, if I could dream up a study, it would be like, what is happening during different activities? Like, what's happening during running? What's happening during cutting? Like, more than just treadmill walking. I haven't come up with a good way to address that. yet. And of course, longer term, right? Our longest term studies is only 6 months. So can we bring these dogs back 5 years? What's happening with joint stability at that point? Maybe the dogs with subluxation are now all resolved or not.
Yeah, there's so many unanswered questions. And I'm, listening to your talk, I'm thinking of one of our later speakers, Professor Mike McNicholas, who's a human surgeon, and he must be thinking, there are huge differences in the way that we manage ACL rupture in veterinary medicine compared to human medicine, because I guess back in the late 80s, there was that fork in the road where we went away from trying to reconstruct directly the function of the ligament and actually looking at biomechanics and doing osteotomies. And it's interesting now that, you mentioned the brace, we're kind of looking to kind of recombine those approaches. Because obviously the canine knee is very different to the human knee in terms of its biomechanics. So there'll be some interesting discussions later, I'm sure. So,
absolutely, yeah, and there's a lot of great work coming out of different groups looking at revisiting intra-articular reconstruction, and that's kind of the holy grail. And it would be really cool to kind of validate, at least gain a better perspective on how those are truly working with studies like what we have done in the past.
Yeah, absolutely, brilliant. Thank you very much, Dr. Kim. Thank you for giving us your time. Really fantastic data. Really enjoyed watching that, and we appreciate your participation in this evening. Thank you.
No problem. Glad to be here. Cheers. Thanks a lot.
Okay, so we will move to Mark Morton, and Mark's the clinical lead for the Cruciate Registry, if you weren't on the webinar earlier, and he's going to tell us in a short space of time, 15 minutes, how the Cruciate Registry works. Over to you, Mark.
20 minutes. Let me share my screen again. Thanks to Stan for that great talk. The question that you asked me, John, about success, the answer is we need thousands and thousands of cases. So there we are. So this is going to be a whistle-stop tour of how the Cruciate Registry works. We are limited in what I can go through, but I'm going to try and show you as much as possible in the next 20 minutes or so. So the functionality of the registry is also all based around the workflow that we looked at earlier on. As a reminder from earlier, once a cruciate rupture is diagnosed and surgery is advised, the project's discussed with the owner at that stage, and they're enrolled on the online portal. They then provide consent electronically. They complete a baseline questionnaire about their dog's lameness. The surgeon then completes a surgical report form detailing all the information about the surgery. And then the owner is contacted on a regular basis throughout the rest of the dog's life. So 6 weeks after surgery, 12 weeks, 6 months, a year, and then every year after that, with further questionnaires, and they can report complications, etc., etc. Before you can use the registry with patients, what you need to do is register as a veterinary surgeon. And to do that, we use the registry website, which is absolutely fantastic. Thanks to Ricardo for putting it all together. It's way beyond what I imagined, and the rest of the team at RCVS Knowledge. You've helped a lot with the content, editing it and putting it all together, and all our contributors as well from the advisory and steering groups. It's great. So just to sort of show you the registry website here. Read this at your own leisure. There's lots of information about the registry. There's some nice videos. There's information on why you should take part, etc. So please come back and go through that. It's online now at www.caninecruciateregistry.org. At the top, there's sections for both owners and veterinary professionals. On the owner section, there's some information about the commonly performed procedures. We'll come back to that in a second. There's some information about cruciate ruptures in general. If you want to register as a vet, this is where you do it. So you go to the veterinary surgeon registration form. It's pretty easy to do. And this is where we sort of log all the demographics about the vets who were involved. So in order to register, you need to provide us with some data, so we know who you are. As I said, this is all anonymous, so you can see your results, but nobody else can see your results. You need to supply your RCVS number. There's a link there to find it, your name on the register, and that's so we can check that you are a vet. We found out in the trial that some people have different names on the register to that which their clients know them by. So again, there's an option to put in a different name there. You then register your practice. If you are, for example, a peripatetic surgeon, or you work at multiple branches, you can add multiple practices there. With the postcode, you can track how surgeries did at different practices, and identify potential issues with infection, for example. Going further down, this answers one of the questions that came in. We're interested to see it, what sort of differences, sort of skill level or further training makes to outcomes. So if you have any postgraduate qualifications that are appropriate or sort of linked to orthopaedic surgery, you can select them there. And then there's an option at the bottom there to select whether you're an advanced practitioner or a specialist. This bit here, the delegate section, is how you can involve the rest of your team. So one of the issues is we'll all have with this is time to do it. So if we can involve the whole practice team to encourage people to get involved, all the better. So you can register a delegate, whoever that may be. It might be a colleague, it might be a vet nurse, or a member of the administrative staff at your practice. They can have access to your account and register patients on your behalf, input data, etc., etc. So you can register delegates as many as you want when you enroll, or you can do that at a later date by contacting Amplitude directly, and they will register those people to your account. It's important that you trust those people because they will have access to all your data. Okay. Back up to the top, as I say, go back to the website after the meeting tonight and have a good look around. This is the owner section, and I hope this is a good resource for both owners and vets to use. There's some really nice info sheets about all the commonly performed surgical procedures. Becky Jones from the University of Liverpool has drawn some fantastic diagrams for us, which, as well as owners being able to go and have a look and digest what procedure might be going on, I think these might be useful for vets to go through with owners as well at the time of consultation. So we hope that is all useful. Once you're registered and you're seeing patients with cruciate ruptures, the next step is to start enrolling patients. After a consultation where you've diagnosed a cruciate rupture, all you need from the owner to register them is their email address. Verbal consent to do that is absolutely fine. Further electronic consent for their participation in the project is given further on or further down the line when they get their first set of emails. The time to discuss this with owners is at the time of consultation. We need pre-operative data. They need to be on the registry for you to be able to log the surgery. Okay, so it's important that you discuss it at that time. My experience with using this in a trial is, once you get into the swing of things, it's really easy to explain to owners. I haven't had a single owner who hasn't wanted to get involved, and they've all sort of completed their questionnaires. There's an information sheet on the website that you can download and give to owners, which explains about the project and what they're enrolling in. That is available as an electronic version as well, but there's a sheet that you can print off and give to owners. So this is how you add a new patient. It's really straightforward. Go back to the website, go to the veterinary professionals section, go to the new patient registration form. All you need to do is stick the owner's email address in and their name. That could be in whatever format you want. The name of the patient. Don't forget the email address. That's absolutely key for us to be able to contact them going forwards. And we also there's an opportunity to put the name of the vet treating the patient in as well. Sometimes it can be a bit difficult for owners to remember, and if there's lots of vets visible on the portal, at least on there it is. You can check the information and then submit that. You get an acknowledgement, and then there's a little tab at the bottom if you want to add another patient at the same time. If you're having a busy day, you can stick another one on there as well. Once an owner is enrolled, they will receive an email inviting them to take part. That's where they give their sort of full consent and complete their baseline questionnaires. All the follow-up emails and questionnaires are very similar to the baseline that I will show you now. when they receive follow-up questionnaires throughout the rest of the dog's life, there is also an opportunity for them to report any complications, whether they're new or historic. I think that the wording is actually since you last completed a questionnaire. Vets can also input complications at any stage via the registry portal. So this is what your owners will receive, or pet owners, if you're joining us tonight. This is what you will see when you receive your email. So as we record the patient's gender, we need the animal's date of birth as a unique identifier. If you don't know your dog's actual date of birth, it doesn't matter as long as you use the same date every time you log in. If you just go the first of the month or whatever it may be, as long as you know the year, obviously, for calculating age. Name, and then you select the vet surgeon who's treating your patient. I'm going to select myself, and then you select what's called a pathway on the Amplitude portal. And although I might sound like a robot doing this presentation, I can confirm that I am not. It's a security feature. And then you need to choose a secret question, or that you will be asked the answer to when you log in, again, for security. If you haven't worked that out already, I am from Liverpool. And then again, to register with the Amplitude portal, we need your email address, and a postcode from a demographic point of view. There isn't an option with our registry at the moment to receive updates by text, so it's simply email. And then there's a few more questions here. So, has your dog been neutered? This is where owners go through their consent. You can read this on the Cruciate Registry website. And then that's registration done. So the My Details section, you can go in and check consent. And then this is the baseline questionnaire. So to start off with, there's just a little bit of more history. So you select the breed of your dog, which leg is affected, how long your dog's had the problem, have they ever had cruciate surgery on the other leg, and that's important for our future analysis of this data. Are there any other problems? Our outcome measures aren't limb specific, so it's important to know if the dog's suffering from any other problems. And then the owner goes through, this doesn't take that long, and completes the baseline canine orthopedic index questionnaire, followed by the baseline load questionnaire. You get the general idea of all these sort of questions here, so we don't need to sort of see them all answered. Owners may say that some of these, they're being asked the same question several times. There are subtle differences in each of these questions. They may seem similar, but they are different, and it's important that we have them all completed, and we can't take any questions out because that affects the validity of the questionnaire. So again, we don't need to see all these answers, but this generates the load and the COI score all automatically, and you can view that on the registry portal. So once you've done that, if at any stage the owner wishes to withdraw consent from the project, they can click down here. They can go to manage consent and they can withdraw from the project. Again, thanks to Amplitude Clinical Outcomes, the whole team there have done an amazing job of transferring a human portal over to the vet world, and we're their first veterinary client, and it took a lot of working out between us all, but we've developed what I think is a great portal for canine patients. The next step is the surgical report form, and this is really important because all subsequent communication is with owners is triggered from the date that this surgical report form is completed. So as a veterinary surgeon, once you're registered, you can log into the portal and you find your patient of the day. You can set up work lists, etc., etc. Have a look at the user guides. It'll tell you how to do all this step by step. If there's anything missing, please let us know. So you can see what the owner answered. So which leg they thought that the dog had a problem with. Most owners will have put the breed in here, but with that's sort of missing. It won't have this test system branding on. That's just to preserve anonymity from any of my clients that I have on the registry at the moment. We record body condition scores. So when you select breed, you will get the most appropriate size dog images come up here. Thanks to Royal Canin for letting us use their images. Was it a bilateral at time of surgery? what was the dog's weight, etc., etc. A bit from the clinical examination. Next thing is the surgical report itself. With this advisory group, we've tried to include all the most commonly performed procedures with as much, you can record as much data as you want. So when you select which procedure you're going to perform here, it populates a different set of questions for every type of procedure. A lot of work was put in by the advisory group developing this data set. We've tried to cover as much as possible. It will not be perfect. If there's something missing, please let us know. We can add it on, no problems at all. If there's a particular implant that you use that isn't on there, or a manufacturer, please let us know. We can add it on without a problem. You can set up defaults here. So if you do TPLOs all the time, you can say what your routine is, and it will automatically populate that. And you might just change size of blade, size of plate, etc., etc. So you can speed up inputting this data. So once you select your procedure, you'll also select, did you do a joint examination? Did you scope it? Did you do an arthrotomy? Was it a complete rupture? What happened when you assessed the meniscus? If it was torn, you can select what type of tear it had. Thanks to Tim Vogt for letting us use those excellent images of the commonly seen types of meniscal tear. For TPLO, record your pre-op angle, your planned post-op angle, and again, I won't make you sort of go through my whole surgical report, but what blade you used, what your rotation was, etc., etc. Any additional procedures? Did it have a patellar luxation? Did you give it antibiotics? When did you give them? Did it have a nerve block? How did you close it? What was your surgery time? All factors that we think may affect outcomes. Okay. There's a section at the bottom as well to record your post-op instructions, so antibiotics, drugs, etc. Whether the dog had physio. We hope to develop that section going forwards. Diane Messam, who's an physio, head of physio at Davies Vet Specialists, runs their rehab centre, has written an excellent piece for us about rehab as a sort of owner guide, and she'll help us develop a little bit of added info on what we should be recording from a physio point of view there. From a reporting point of view, as we said earlier, we don't have enough data yet to show you a dashboard and what it looks like, but that will be put on in the coming weeks. There's instructions in the user guide on reporting, and we'll set up some online training for anyone who's interested, just to, a quick half hour here or there in the evening maybe, or the afternoon, just to show how to do the reporting. So in summary, if you're a vet and you want to register with the Cruciate Registry, please do. It'll be open after the meeting for you to register. You do that on the website, as we said. Your registration will be checked against the RCVS Register of Members, and it might take some time to process all these applications over the next few days, so please be patient. You receive a link to the registry to join and give consent. That link is valid for 24 hours. Please check your junk mail, because a few people have lost the link in there. If you need a new one, contact Amplitude directly. You'll give consent and you'll receive a copy of the user guide. From an owner point of view, if you're an owner and you want to be involved with the Cruciate Registry because your dog's got a cruciate rupture, please in the first instance speak to your own veterinary surgeon, who can let you know whether they're participating. If you're a vet and you want to guide owners to this, as I said, go to that register a new patient bit on the website, and everything will be done by email, and then the owners will have access to their own portal. Again, on the registry website, there's loads of information sheets there and user guides, FAQs about the portal and how to use it. I think the owner guides are going to be, certainly for me, really useful to direct owners to and to use with owners. There's info on there about cruciate ruptures, procedures, outcome measures, what we're looking at. And as I say, the rehab one will be on there shortly as well. We'll run some online training over the next few months to help people get used to using it. It's pretty straightforward, I think, once you get used to using it day to day. If you have any questions, if it's about the portal itself, your registration, you've forgotten your password, whatever it may be, please contact Amplitude Clinical Outcomes on that email address. They have a fantastic customer services team who'll help you out. If you've got any questions about this project, or you want to contact the steering group directly, if you've got any ideas or you want to be involved further, please email ebvm@rcvsknowledge.org. Happy for people to contact me directly. My email address is there at the bottom. If you've got any suggestions, whether that's about the portal, whether there's something missing, ideas of things how we can develop this going forward, please let us know. If you've got any suggestions or improvements that you'd like to see on the website, again, please contact us on those email addresses. All I would finally say is please register now. This project relies on vets and owners being involved to develop the data we need to help us treat our cruciate patients in the best way possible, maximize outcomes and minimize complications. Help us, help you, help your patients. I'm quite biased, but I think this is a fantastic tool, and we're really lucky to have this at our disposal for our cruciate patients. When I say register now, please wait till the end of the talks before you jump on. I'm happy to take any questions that there are, or we can do some more at the end. I'm sorry, that was a whistle-stop tour, but there's a lot to cover.
Thank you, Mark. Really good. There are more questions coming in. I think hopefully some of them have been answered there. So there's a question from Lizzie Whiting. Hello, Lizzie. Hope you're surviving amongst all the tourists in Cornwall. Question about when to engage owners with this, and is there information that we can direct owners to? But hopefully, I think you've answered that, Mark. There was another anonymous question here about should we market this to breeders and owners, or is it always down to the frontline vet to initiate engagement with the survey? I think it's down to the vet really, isn't it? Because it's a surgical registry. Sorry, you're on mute, Mark.
So, sorry, can you hear me now? Yeah, quick answer on that point of view. Yes, I agree. Surgeons need to drive this, but we want owners to be saying, and what, are you involved with the Canine Cruciate Registry? I want to go and see a surgeon who's involved in the Canine Cruciate Registry. So yeah, we'd encourage all the sort of breed societies and things to get involved and speak to us. Happy to help out with engagement if we can.
And I'll just do one more and then we'll move on. Someone asking here, will different categories of surgeon be identified? They're looking for assurance that advanced practitioners will be differentiated from specialists and GP.
Yeah, so we record that information at the time of registration, and that's the reason to do that. So you'll be able to compare yourself against similarly qualified peers. And also we'll analyze that as well to see if experience etc makes a difference, and just because you're a specialist doesn't mean you're really experienced with one type of procedure. So a little bit of a caveat there, but I think it'd be interesting to see what the outcomes are there.
Great, thank you, Mark. In the interest of time, we'll hold those other questions till the end, I think, but thank you very much for that, Mark. Really informative, and it's great that people have got the contact, so if they've got questions, they can fire those questions into the relative email addresses. Okay, so it's my next job to introduce someone who's very nearly as old as me, and that's Professor Duncan Lascelles. And delighted to have Duncan joining us this evening to talk about assessing clinical outcomes. When Duncan has the chance to introduce me ahead of the talk that I'm giving, he usually shows a really embarrassing photo of me. I'm not going to do that to you tonight, Duncan. You've got some of your friends in the room there, I see. It's great to see you.
Yes.
And
Yes.
Thank you for giving up your time today. I know it's in the morning there in North Carolina. And thank you for that. And we look forward to hearing your expertise around clinical outcomes. Thank you.
Thanks very much, John. And thank you, Mark, for the invitation. So let me just get set up here. And this will be like a two-stage process as I figure out which screen I'm sharing. And let's do this one. Okay, so you should be seeing a single screen now. So thank you. Thank you for having me give this little presentation. It was actually a really interesting thought process here so I absolutely work in the area of outcome measures with respect to orthopedics, with respect to musculoskeletal disease. I've done very little work directly around cruciate ligament disease, although I am fascinated by the by that as a disease, and particularly about the effects of muscles around the joint and how they affect outcome. But what I'm going to do for the next 15-20 minutes here is to talk at a high level about the different outcome measures that are available that we could use, and then give a little bit more information around, you've already heard about the load and the Canine Orthopaedic Index and some of the pros and cons, and maybe just sort of set the scene as to why those are being used in the Canine Cruciate Registry. These are my current disclosures from over the last 3 years. The only one that I think may be relevant to what I'm going to be talking about is, you see down at the bottom here, I'm a co-founder of a little company that will probably go nowhere called Anovate. So outcome measures, these are, it's kind of a posh term for assessments of how good, bad the outcome was. And these are important because we want to evaluate different procedures. You know, we want to know which procedure is better than another. Owners would like to evaluate surgeons, and that may be in the future, although as Mark indicated, that's not that's not a place that the registry is going at the moment. And with an outcome measure, with an evaluation of different procedures, we can then do cost-benefit analysis. And I think this is really important, you know, looking at what benefit you get for what cost. Something I've certainly heard Mike Konzemius talk about quite a bit, and it's a challenging thought process there. So let's just look at maybe, and this is very simplistic, different people will present this in different ways. Let's just look at maybe what the problems are. So cruciate ligament rupture is going to result in mechanical changes and pain, and those are certainly interrelated. And each of those, the mechanical component, the pain component, can be broken down into a number of different aspects. Mechanical changes can cause pain. Immune-mediated processes that may or may not be involved can contribute to pain, as can inflammatory processes and the other processes involved in the development of osteoarthritis. And similarly, mechanical aspects can be broken down. Then, because of the combined mechanical and pain, to a greater or lesser component of each of those, we end up with altered or decreased limb use, and that's one of 4 limbs, and that's going to have effect on the whole animal and will alter / decrease the ability to function, the ability to perform the activities of daily living. And going along with that, we can then break out and look at muscle atrophy if a limb is being used less. And as a result of altered limb use, altered ability to move and function, there may be changes in activity and movement that could be measured. So now I'm going to go through and just look at, so that's kind of how I break down some of the problems and the consequences of cruciate ligament rupture. And obviously, when cruciate ligament rupture is addressed surgically, you'll be looking to reverse these, to remove these problems. And so, you know, what are the kind of outcome measures we could think about? Well, certainly, you know, my area is pain, measuring pain, and I've spent a lot of time confirming that there are no good local or systemic biomarkers at the moment. Although I have to admit, you know, I always have a favorite one. My favorite one at the moment is cartilage acidic protein 1. We could use QST, looking at the impact of pain on the whole patient and changes in sensitivity. As we drop down and think about altered or decreased limb use, this is kind of where we probably feel most comfortable as orthopedic surgeons. We can think about kinematics. We had a beautiful presentation earlier on about the looking at the movement of the joint. We can measure ground action forces, either kinetic or static, and surgeon observation. Just to provide a few words about these, I think force plate analysis, pressure platform analysis, the measurement of ground reaction forces during walking is something that's often held up as being the gold standard. And it's a really good measure. It is objective, and certainly, you know, provides us with information about how that limb is being used. But we also got to think about what it doesn't provide. It simply measures ground reaction forces. So the limb may not be being used normally even in the face of normal ground reaction forces. Now, I'm pushing the limits here a little bit, but for each outcome measure, you have to think about what it is actually measuring. And so here, kinetic measures of ground reaction forces are measuring exactly that, the ground reaction forces. But a wonderful objective way of, as you can see here from this lovely study published in 2016, assessing the different procedures. There was a lovely comment earlier on which really relates to generalizability. Many of the studies you see published here are performed in small numbers of animals in secondary, tertiary, referral type centers. And so one does have to question the generalizability of these data to the broader population. And the problem with this, it's a wonderful measure, but equipment is expensive. Even beyond that, you need room to set these force plates into a runway. And so it's not something that's necessarily going to be able to be used in every practice. And also there is a need to standardize methodology, analysis, and reporting. And there's a meeting I'm part of organizing coming up. It's a POR meeting where we will be drilling down on this and hopefully producing some guidelines. Another measure of ground reaction forces is the measurement of static ground reaction forces. Some equipment is relatively cheap. Essentially, all you need are 4 bathroom scales, or if you're just interested in the hind limbs, just 2. The match you see down here is a £45,000 version of a few bathroom scales and allows us to measure body weight distribution. Collection of these data is actually quite difficult. Getting dogs to stand in a relaxed, normal way, the way they want to stand, that is difficult. Potentially it's more sensitive than kinetic ground reaction forces as a measurement of lameness, potentially. And I do think it reflects spontaneous pain, which is another aspect of what is caused by cruciate ligament rupture. So there's spontaneous pain, there's induced pain. If you think about kinetic ground reaction forces, they maybe relate to induced pain, the pain induced by walking. Here, you're potentially looking more at spontaneous pain, the desire to offload a limb. But I admit, you still got to have a ground reaction force coming up through that limb. And anyone this is a cruciate ligament rupture dog here, it's actually bilateral. If you've watched these dogs in the consulting room, you see this offloading here, which can be readily measured. You can see this is a bilateral case as it sits down there. Surgeon observation, not much to say here, except that we, veterinary surgeons, are not that good. Lovely study by Mike and Zemus's group here. And remember, there are so many biases come in. When I'm assessing patients, I'm looking for problems. When I'm assessing outcome of my surgery, am I really looking for problems? So moving down here, so the altered or decreased limb use will affect the function of the whole animal. Now we start to get into how can we assess that function globally. And here we move to thinking about owner observation, so-called clinical metrology instruments, or as you've heard them referred to, client-reported outcome measures. The solid green there it's essentially is supposed to speak to the fact that these outcome measures are assessing the whole dog. There are not as yet valid client-reported outcome measures that really focus on a single limb, and I'll touch on that later. So metrology is measurement-based informatics. A clinical metrology instrument is a sequence of questions, essentially a questionnaire that relates to a clinical disease or process. Response is based on subject or proxy assessment. So here we have a proxy, the owner assessing their pets, just as the owner of a child might assess their child, just as the parent of a child might assess their child. And the responses on these questionnaires are used to generate an instrument score. So you put a number on it, but as I'll mention later, these are subjective. Now, these questionnaires, they do look simple, but they need to go through processes of validation, because without going through the process of validation, a questionnaire simply tests one's preconceived ideas of what may or may not change. And just think about that. That's really important. We can all come up with questionnaires to assess all sorts of things, but essentially all we're testing, unless we have evidence that they are good questions, all we're testing are our preconceived ideas of what may or may not change. And so you can see the stages of validation here. To truly validate a client-reported outcome measure could take 10 to 15 years of clinical studies and research to develop it properly. Now, these are, as I said, subjective, and they do not, even when they're referred to as validated, they do not inherently remove biases or the placebo effect, however you want to refer to it. For example, owners are answering questions, and they will change their answers depending on the contextual environment. If I hand an owner a questionnaire and say, your dog's looking great, I mean, it looks so good, hope everything's going well, answer the questionnaire, the owner's probably going to be more positive. Whereas if I hand them the questionnaire and say, oh, I hope everything's going okay, looks like there's a bit of a limp still, they're going to answer more negatively. So there's certainly biases, contextual biases here. And these questionnaires, when people refer to them as valid, they're most valid in the context of a placebo or sham-controlled blinded scenario because of that subjectivity. That said, they capture the owner's assessment of function in the normal environment, and we are interested in normalizing function of these animals in the home. It allows clinicians a measure of this disease or process and generation of consistent information. We can follow changes over time, interpret results of interventions, and it allows researchers to speak the same language. It essentially gets everyone on the same page. So there is a lot of utility in these, and a number of them have been developed. You can see here the list, the Liverpool Osteoarthritis in Dogs Index, the load, the Canine Orthopaedic Index, there's the Canine Brief Pain Inventory that's been described, the Helsinki Chronic Pain Index, the Texas instrument, not one that's talked about much, but quite a nice little instrument there, and the SNORE, the Sleep and Nighttime Restlessness Evaluation, which is really focused on sleep quality. So a number of these have been introduced, and they've all been validated to greater or lesser extents. What these measure are multiple dimensions, depending on the specific questionnaire, multiple dimensions that relate to pain, function, well-being. For example, the load. Mark talked about this earlier on. The load really appears to be a measure of 3 components or dimensions. There's an activity exercise component, an effective weather component, and a stiffness lameness component. And that actually stiffness lameness component is important. And I think that's why the load is actually pretty good at assessing single limb function. So these client-reported outcome measures, these CMIs, they're either set questions, such as the load, the CBPI, the COI, or patient-specific questions. We're not going to get into the CSOM now. But an important point to make here is all of these have been developed to assess the impact of OA pain, osteoarthritis pain, on dogs. None are specific for assessing the impact of cruciate disease. None have been developed to specifically assess the impact of cruciate ligament disease. Now, cruciate ligament disease, we're looking at a single joint, we're looking at a single limb. Sure, it can be bilateral, but we're really looking at that single limb. And all of these CMIs, all of these CROMs here have been developed to assess OA pain in dogs, and part of the validation has been through the use of systemic analgesics. Now, they've been developed to measure OA pain. They've been developed to measure the impact of OA pain. The CBPI actually asks about pain directly. The load doesn't ask about pain, it focuses on function. But the important thing here is all of these have been developed to essentially assess dogs that have multiple joint problems, as most dogs with OA do have, and the efficacy of systemic analgesics. and none are specific for cruciate ligament disease. Now, that said, if you engage in the Cruciate Registry, and I do encourage you to do that, you'll be using the COI, the Canine Orthopaedic Index, and the load. Now, I've pulled out a little part of the Canine Orthopaedic Index here because I think although it's not been looked at, some of these questions may be very good for single limb problems. And the load is also pretty sensitive to changes that are related to single limb problems, even though it was developed to assess more broadly OA. But critically, what it was, I'm going to jump to this one, how the load was developed was using dogs with essentially a single forelimb lameness due to elbow OA. And that's very different to all the other CMIs that we've talked about. So the load was developed, it was set up, it was developed, it was evaluated, it was refined, it was validated around, starting around dogs with essentially a single limb lameness due to elbow OA. And that's why the load appears to be most appropriate out of all of those CMIs I talked about for assessing single joint function and pain. And I'm just going to show you a few graphs here, not related to cruciate ligament disease. This is the pain severity score of the CVPI. This is the pain interference score of the CVPI. This is the CSOM. This is the load. These were used to assess a very effective treatment given into either elbows or stifles for the management of OA pain. And you can see here, so the gray line is the sham, the green line are the treated animals, and the load produced the biggest separation. The load detected the therapeutic effect, a therapeutic effect that was seen in humans here. Okay, so same compound given intra-articularly into knees of humans, producing a dramatic analgesic response. That was detected by the load. So we're talking about treating a single joint here in a single limb, and the load is able to detect that. So that's a kind of a long-winded way of saying I really think the load is very appropriate. And because I think of the way that it was originally developed by a very young John Innes and colleagues. Now, a couple of other things just to touch on, to finish up with here. A lack of use of a limb will lead to muscle atrophy. And I think that's an underserved outcome measure here. Now, here's me rather quickly assessing quadriceps and then hamstring atrophy, so use of hands. And then here is my colleague Masataka Enomoto. What looks like a more scientific approach using a GULAC-2 tape measure, but as anyone who will know who's measured their own waistline, it's quite easy to adjust that. And also here in the dog, you are trying to measure the circumference of a cone, and it is difficult to get consistent measurements there. So we drop down here just to finish up with, how about altered physical activity? Now, there's very little data to indicate that overall physical activity is altered in dogs with cruciate ligament disease, but it's a good starting point. I think it's an appropriate assumption as a starting point. And physical activity can be measured using accelerometers, so-called physical activity monitors, or even IMUs, inertial measurement units. So you can have a simple accelerometer. It can be a single axis, tri-axis. You can move then to add in a gyroscope, a magnetometer, which is essentially an IMU, a 9-axis IMU. Now, there's no such thing as a unit of activity. Every device spits out a value depending on the internal processing of the function of that unit. Physical activity monitors are objective measurements. It's an objective measurement of activity. It's an objective measurement of all activity, whether that's eating, scratching, walking, or riding in a car, and that has to be remembered. The data, though, is captured in the home environment, and I think that's what we want to be moving to is here. How do we capture data in the home environment? So those are a couple of positives. On the downside, there's actually little scientific understanding of what data mean. All the data that we can collect, there's huge inter and intra-dog variation in activity, which makes it very difficult to come up with normal values. It actually means it's quite difficult to even to see changes over time. And that's particularly true of means and averages and totals, and probably patterns will be more important. You can see here, this is actually some data from cats. There's no difference, at least in this study, between the total activity of cats with DJD and cats without DJD pain, but the pattern's different. And we've seen the same thing in dogs, both in induced models of OA and in naturally occurring OA. The problem here, though, if we're thinking about this as an outcome measure to assess cruciate surgery interventions, we really need a baseline. You know, where were we before the problem, and measure activity to get back to where we were. And we're unlikely, until most dogs are wearing physical activity monitors, we're unlikely to have that. I think there's actually maybe a little bit more potential for this idea, and for full disclosure, this is part of my academic work at NC State, but also has formed the foundation of starting this little company here. And this idea is around measurement of smoothness of motion. So movement smoothness is a quality related to the continuality or the non-intermittency of a movement, independent of its amplitude and duration. And to be able to do this, you need to be able to measure, you need to be measuring acceleration and change with a gyroscope at a high acquisition rate, 50 to 200 hertz. And we've certainly, gathering data like that, we've been able to detect differences between dogs with and without OA pain. And I suspect this may have utility in dogs with cruciate ligament disease as well. Now, whether the monitor should be applied to the whole animal or whether on that individual limb remains to be determined. So finally, to finish up here, just a kind of little fun glimpse of what I firmly believe is going to be the future. There are going to be apps that will be put in the hands of owners, and those apps will video record dogs and will give a readout on normality for different types of disease processes. In this case, we're looking at cruciate ligament disease. Apps will be developed to give a score, normal, not, and scores in between. And how that will be done will be by training algorithms. This is a research assistant of mine who played with pose estimation during the pandemic last year at home. All the tools are available online to do this. This is a dog that I marked up quickly this morning. And so one way of training the algorithm is to train the computer to recognize different parts of a dog. That's pose estimation, essentially markerless kinematics. And you capture video in a variety of different situations once, and you capture normal and abnormal subjects, and you essentially train the machine learning to recognize abnormal and variations in between, and then the algorithm can be applied to video that's collected, say in this case by owners. The other approach is a complete black box, and so you feed into these convoluted neural networks and machine learning, you feed in video of animals that are known to be normal, known to have cruciate ligament rupture, known to be a grade in the middle, and you leave it to that machine learning convoluted neural network process to determine what to look at. The problem with the black box approach is, in the end, you really have no idea. If the algorithm is successful, you have no idea what was actually being looked at. But this is the future. This is where things are going. For the moment, though, might not look quite as sexy, but the load is probably the best outcome measure that we can put in the hands of owners to capture that incredibly valuable information that owners have in front of them every day with their pets. And with that, I'll be happy to answer any questions, or we can come back to questions later.
Duncan, thank you so much for that. I often refer to you as the king of pain, and I mean that in the most kind way, because of all the work that you've done around comparative pain research and improving pain control in dogs and cats. And I introduced you in a very informal way, but that's because we're great buddies and have been for a long time.
We are.
But your work is incredible, so thank you very much for that. It's also interesting to hear, I'll declare obviously my interest in the load as the developer of that, hear that reflected back. And that's interesting from your your perspective on that. I suppose going back before the load, when I worked on a cohort of dogs with cruciate rupture, I developed sort of embryonic load, which was the sort of Bristol instrument back then, and that was based on dogs with cruciate rupture. So I suppose actually the older cousin of load was based on dogs with cruciate rupture. So maybe that's why there is that bias towards single limb problems in those instruments. And it's interesting to hear you tease that out in the data that you've got.
Yeah, no, it's certainly been something that we have found repeatedly, that it's the load that is able to pick up localized treatment effects. And I was looking for that Bristol outcome measure paper, but I believe it's written on papyrus. Is that right? It was a while ago now.
Yes, it was a long time ago. Maybe stone tablets, actually. Yeah, thank you for that.
You're welcome.
You're only a month younger than me, remember, my friend. Duncan, we may have to defer. Are you able to hang around till the?
I can, yes, absolutely.
Okay.
I'll go into the background and hang around.
Thank you. That's a real privilege. Thank you. And we'll move on to our last speaker this evening, and we're very, very lucky to have Mr. Mike McNicholas with us this evening. I'm sorry, Mike, we're a little bit late introducing you. Apologies for that, but we're really pleased to have you with us because you bring a wealth of experience from the human orthopaedics side. You are on the steering group of the UK National Ligament Registry. You're a well-known orthopaedic surgeon internationally, and you're also on the involved in the International Cartilage Research Society as well. So you're a very busy man, and we appreciate your time this evening. And without further ado, I'll hand over to you and I to present to us around experiences in the Human Ligament Registry. Thank you, Mike.
Thanks very much, John. I'd just like to say what a massive honour it is for me to be asked to present in such an interesting meeting. And it's been fascinating to see the work that you have all been doing, which very much mirrors the activities that we have been trying to do in the human. Let me just see if I can shrink this down so it doesn't affect the screen as much. So I'm, as you said, I work on the ICRS. I'm chair of the registry committee there. I've worked with the Ligament Registry in the UK for the last 7 years. President of the Biological Knee Society, so very, very much interested in joint preservation rather than replacement. Normal clinical practice is in Liverpool, and academically at the moment I'm associated with the University of Manchester. However, at the moment I'm on holiday and I'm talking to you from Thurso on the north coast of Scotland, and that massive fish there took me about 20 minutes to reel in yesterday. So I'm very happy that that I'm here to speak with you all today. So in terms of interests, there are a number of different companies that have sponsored work that I've done and active consultancies, but none of them really affect the subjects of this evening's presentation, other than in the models that we've used in the human world, the generosity of companies has been required to be able to set up and run the registries. And I think the fact that you have your professional association supporting you financially is a massive advantage, and I think will add to the sustainability of your endeavours. This is another declaration of interests, and I have had 3 golden retrievers over the years. This is Mac and Milo, and unfortunately they both went on to suffer cruciate ligament injuries later in life, but with successful treatment with TPLO, were able to play and enjoy the rest of their lives. So I've seen the power of the technique that you use. I've adopted it for humans where we've run out of options for revision of multiply failed ligament reconstructions, and the TPLO concept really helped me to understand how slope alteration in a human tibia is so powerful for soft tissue intervention. So we concentrate mainly on our experience with registries, and there are a number of documents that I'm sure that you are all very aware of on the steering committee about what the essential features of a successful registry are. And I think that you've exemplified those hugely in the way that you've worked together in the planning stage, The data set that you have and the instruments that you're using being gold standards is great. The data management, I know that Amplitude will be able to help you. Both the ICRS and the UK Ligament Registry have worked with Amplitude for years, so that they will help with that. But there will be some challenges as you move forward, and it's great that you've looked into those and you're aware of them. And the issue around the completeness of data moving forwards is something that is going to be a problem for any of us that want to look at long-term outcomes. But I think that you've got the massive benefit of all the work that you've done, and that you will have a successful registry over time. And in the human sort of sphere, I have recently worked with colleagues from Japan, the States and Israel on a review of all of the literature on the use of registry data in knee problems, and written a state-of-the-art publication, which is in its final stages of publication now with the Journal of ISICOS, an international sports knee association. And when we looked into the literature, there were 38 registries that dealt specifically with the knee. The majority of those were in respect of studying outcomes of joint arthroplasty. There were 8 specific to ligament surgery, 4 around osteotomy in the human knee, and then 3 looking at articular cartilage work. And a number of them will be of use in your moving forwards. So our first ligament registry was one in the States, the Moon Group back in 2002. And a number of Scandinavian countries used their experience with arthroplasty registries that they've been doing for a long time, back in 2004-05. And then in 2013, colleagues set up the UK National Ligament Registry, and I joined them shortly afterwards. And we've just presented our 6th report, despite the difficulties of the pandemic. Most of us have achieved follow-up times varying between 1 and 3 years. And a number of the registries for ligaments do have the aim of a 10-year post-op follow-up, but none of us have actually achieved that yet. And a bit more specifically about the UK National Ligament Registry, these are the aims that we set out with, and they're very much the same as the aims that you have been expounding this evening. So we want relevant demographic data, look at trends in practice, and then if we can, try to identify if a newly introduced technique isn't doing so well before thousands of patients, or in your case, thousands of animals and families, are going to be adversely affected by things that may be done better, and try and identify those at the earliest opportunity. That then would give functional outcome data and complication rates, and I've got some comments about that later. But basically what we're all trying to do is improve the standard and quality of care here in Britain and around the world as a result of actually knowing what we're doing, which strangely enough, we tend not to know a great deal about. So ligament registries in Scandinavia started, as I said, between 2004 and 2005. They have a huge data set now and over 70 peer-reviewed publications from such data. And a number of us from the UK registry joined with colleagues from 6 other countries and looked at the volume of treatment that we've been delivering, and some basic stats and when we started. And so the UK will be the biggest annual input registry because of the size of the practice that we have. But there is a massive amount of information there, and trying to collect the same data sets to enable that information to be fully interchangeable is an established aim for us now. And then looking in a little more into the ligament registries, what are they looking at? So they're all recording data on concomitant injuries, and I don't think that I heard any of you mentioning that other than the meniscectomy issue. So that might be something to think about. You may already have addressed that. We have patient-reported outcomes. You've got your CROMs and CMIs, but we've no uniformity in the PROMs chosen. There are some that are popular in America, some that are popular in Europe. We tried to sit on the fence in the UK with what we were measuring, but then we're inconsistent in the data that we're collecting around the time of operation and during the operation itself. We have a number of registries that look at radiological assessment, but none of them look at the position of the tunnels that we've drilled for the intra-articular reconstructions that you've moved away from years ago by the sounds of it. But some of the older members of your profession may remember that tunnel position is vitally important. And if we're not measuring that, then it's an important data set and we're just not looking at it. And also the importance of healthcare utilization and healthcare costs. I'm sure that you're going to have the same issues if you have insured clients. They're going to want to make sure that they're getting value for money. And actually, a lot of these things have been addressed by UCOR, which is the UK Knee Osteotomy Registry. But one of the problems there is that whilst it's incredibly detailed, you can suffer a little bit from fatigue while you're trying to fill it in. And getting the balance right between the amount of data you capture and getting a complete data set is important. So from my experience with the ICRS registry, I helped to design it. We minimized the data set based upon longer experience with the UK Ligament Registry. We're recently trying to encourage more people from around the world to use it and why we should bother to do it. And I'll run through these. We really want to gain insight, knowledge and understanding of true real-world usage of the procedures. And when we're quoting the outcomes from some world experts that have done this often in a experimental setting, we're not really telling the patient what's going to happen to them or the dog that we're operating on for the family. There are very few early indicators of when these procedures are or aren't giving positive outcomes. We have the same issues that you've outlined, but we've been trying to do it for longer, so we've learned a little. Then, although we all know people that are really busy, we don't know really who is actually doing the most, who's trying out new things. And if we can identify those, then we could share best practice of techniques and experience quickly. We're pretty slow to have realized in orthopedics, in the human environment, how empowering it is to actually know your own data and participate actively in accumulating large data sets. And the power of having similarly minded clinicians contribute to the same cause is going to be of great benefit to canine patients as well as humans. And the surgeon community identifying trends in practice, both at local and increasingly now international comparison level, has been very helpful in a number of ways. So there's a lot of stakeholders, and I heard you mention most of the same people that we have to work with and work for in the talks before. And we need to lead on determining what accurate and meaningful data is collected right from the start. And you've done a great job of that with the steering committee. Registry data is increasingly being recognized as an important area for roles in research, and is actually now being used as a basis for randomized controlled trials where we can spend the money and the time that we have developing these measurement systems and save that for research projects moving forward where randomization is used. The registries have proven themselves as an important tool for observational studies, and there are registries all over the world allowing those groups mentioned there to work together. But on a personal level, I'd like to know how I'm doing compared to how I was doing a few years ago and how my colleagues around the country are doing at the moment. And I'm not sure whether litigation is an issue in the veterinary world, but it certainly is in orthopedics. And it's very powerful to be able to produce your own outcomes to deflect individuals that are chasing litigation when there may not be a real reason for that. And time again in orthopedics, in the human environment, industry partners will deny poor outcomes when products seem to be doing poorly. So the importance of your society having this independent outcome data will allow us to protect our patients and ultimately ourselves from litigation. One last slide of this sort of thing. So the huge numbers that we can get can be used as historical controls for new products and is given an alternative to a randomized controlled trial. And the big data that we have can provide evidence of association, but will never be able to show causation. And so we need to be careful how registry data is studied, and it's great that you are in charge of your own destiny with that, because we have to guide those that might try to misuse the results And there are some of the things that we've learned in other registries as to how to maintain professional buy-in as well. That I'll come to later. So the best way is to interpret our own data with our own societies, be in charge of it all, and be in charge of the scientific output from the registry, all of which you've done. And I'm so glad that you've asked me to speak this evening, and I'm honoured to be able to try and help. So all of these Group C registries is important. We've had 30 years in orthopaedics in the human environment for registries to learn. We've become better at what we're trying to collect and the coverage that we have, and the importance of high quality surgeon validated data using validated scoring systems that are sensitive to change and don't have ceiling effects, which I assume the load and others have been studied about, is huge. So this cooperation is going to be really important. You've already helped with your funding arrangements being better than ours, I think, the long-term future of your own registry. And the issue around the robustness and accuracy of adverse event outcome is something where in human patients, they are very good at saying that nothing happened to them. But if something happened, they're very inaccurate in documenting that. And so we need surgeon validation of complications. And even with that, in a registry environment, we're not able to achieve the kind of rigor that's required for post-marketing surveillance, which is something that our industry partners are struggling to accept at the moment. And then we would all love more help in trying to make a decision, and constant evolution of the registries is going to help improving the ease of data input, allowing understanding of what we're doing and the generalizable real world results that we'll achieve. And so registries are only one piece of the puzzle in trying to answer the important questions around ACL reconstructions, and they fit very happily alongside. They're not trying to replace, but they do definitely add to those other types of studies that you've already been discussing. So our orthopedic main journal in the UK and its editor, Faraz Haddad, who's one of the other members of the UK Ligament Registry Steering Committee, have implored the orthopedic community to embrace all types of evidence. And if registries are novel to your veterinary colleagues, then I think there will be a need to establish the benefits and the great utility of registry data. And they're not there to try and get rid of everything that we've used before, but they definitely add to it. And big data can give great results, but you have to be careful about how you use it. And it's allowed us to ask, what problems are we not really finished with at the moment, and how are we going to sort of aim at that to try and fix it? And actually, something that we don't do very much in human medicine is actually congratulating ourselves on our successes. We tend to focus very much on the negative, and being able to allow the rest of the world to understand how well our patients are faring is of great use. So if we look at a few things that various registries have been able to do, the quadriceps tendon is one of the three main ligament reconstruction graft sources. And there've been some fairly worrying results coming out of the Danish registry, looking at there being an issue of a higher rate of failure of those in Danish surgeons' hands. But one of the problems with it is that there's various different levels of bias. It tends to be used in difficult cases where other grafts have already been either spoiled or have been used as a primary. And so it's important to dig deeper into the data before you say that a quadriceps is a bad graft source, which hasn't been the case in my own hands. However, one of the things that we have used a lot, and it's particularly popular in the States, is allograft. And unfortunately, despite the lack of graft donor site morbidity, the failure rates are significantly higher in allograft. And so I would avoid using allograft while there remains tissue in the individual patient. And happily, as studies have shown that problem and then looked again at practice, the use of allograft has reduced over time. So we can modify behavior of our colleagues by telling them what's going on. The use of vancomycin is something that significantly reduces infection. And in this study in the Swedish registry, the application of vancomycin soaked gauze to the grafts while we're preparing the tunnels has increased hugely in just 2 years. So you can make a difference in a short space of time. There are patient-related factors that we can look at. And again, you've mentioned these. We found that younger patients, although they do seem to do better when they return to their sporting activities, they have a higher rate of revision than their older relatives when they've had their ACL revised. The risks of revision doesn't seem to differ between sexes, but the opposite knee will have a higher risk of of a future tear of the cruciate ligament, which was of interest to us. And as common sense, really, the more damaged a knee is, the less well it's going to do. So these are some of the data that we've been able to substantiate these worries about age-related differences in outcome. The graft choices are associated with higher risks of failure that have been reproduced in different countries, but to different degrees. And size matters. And so if you've got a very narrow hamstring quadrupled graft, then it's got a much higher risk of revision. So we need to be a little cautious about how we interpret data, and it is observational registry. It can show you association or lack of an association, but it's not going to be able to prove causality. And all the biases that have been outlined before are there. There are interactions between variables, and they're going to be difficult to tease apart, but given the size of numbers that we're looking at, then that, you would hope, would be less of a problem. We're not really sure about how to stratify risk yet. And unlike the joint registry, where their endpoint was revision surgery, which is a very poor measure, the softer endpoints that we've been using in ligament registries are the same, with the same issues that you've been chatting about in the previous talks, where pain and function measurement are quite difficult, really. So big data looks sexy. It's there's massive numbers there, so you can get very, very high statistical significance. But whether that actually makes a difference clinically is difficult to say. And there are differences between high volume surgeons that are used to running trials and the outcomes they're going to get than those from a prospectively collected national database. And that is just common sense, because the people that are doing the high volume research are going to be far more focused than generalists on outcome. And so the real world results of registries, I think, are closer to the truth when we're talking to our patients than those of specialists. So one of the biggest risks, if you ask lots of questions, is having incomplete data entry. And so there's variable coverage among surgeons. Whilst in Sweden, as a nation, they're very happy to tell you which field their great-great-grandfathers lived in. In the UK, we're not so comfortable with being measured. And so compliance among surgeons is relatively low in comparison to Sweden. Looking at it, it looks like that sort of questioning fatigue hits at about 20 questions. So you've got to balance the ease of use against it actually just being ignored. And so patients as well, and for you clients, are fairly poor at responding. They're great when they need you, and as soon as things are going well, we think, then they start to burn out a little. These are the issues around what scores were designed for. It affects us in knee surgery in the same way as it did in your brilliant talk that you've just given about the problems there. So we have some scores that were designed specifically for ACL, but the quality of life score, the EuroQual 5, isn't ACL specific. And then most of the registries have failed to include non-operative treatment, which is an important alternative. but with international cooperation, hopefully we'll be able to answer those. So within the UK, there is the hospital outcomes study here looking at adverse outcomes after revision surgery. Huge number of patients using hospital episode statistics. But really, when we looked into what they were trying to tell us, it didn't really make sense in relation to our clinical experience, and they hadn't really validated the data. So the bigger the data set, the less valid it tends to be. Similar issues have been seen with deep venous thrombosis, which is a problem with most surgical interventions in the human. And we have to be really careful about how we define that and whether it makes a real difference or not. So one of the problems that we've seen with the UK National Joint Registry, the one that studies arthroplasty or joint replacement, it's got over 2 million joints in there. It was initially driven by the government after the 3M capital hip replacement, which had performed incredibly poorly. And so it was designed without clinical input, really. So there was poor compliance initially. It's been made mandatory. And then some of the teething issues that they fell foul of there. Who should have access to the data? It was paid for by the government used it. Who could request data? Initially, there was some issues around whether we were going to be able to see our own data or not. Now we have to validate our own data. And whether that should be reported at surgeon or unit level, because if you're in a teaching hospital dealing with very difficult cases, a poor outcome rate could be expected given the complexity of your case mix, but it won't be reflected in the simplistic way that the Joint Registry shows its data. And how valid is it? So we're trying to improve our transparency and accountability, and it's there for research purposes. The plots that you showed before with a funnel plot are great unless you happen to be in that red circle and you're an outlier. And that can then become quite uncomfortable, but it gives you an opportunity to reflect upon your practice, to see if there's an issue potentially with the implant that you're using, or if there's something that you're doing that others aren't, or something they're doing that you're not, then you should hopefully then be able to return to the mean. So there are some criticisms of our ligament registries. As I've said, variable cover. Sometimes we have too many questions there, giving rise to low response rates. And that's internationally quite different as well. So in the UK, patients are quite good at filling things in, really, despite that poor response rate. But in Italy, they really don't want to spend much time on it at all. So we've covered those other points before. So in summary, registry and cohort data can change practice. And I think you're off to a great start with it. Big data can be used, but it needs to be used with interest, and it needs to be really well understood. And the bad use of data, when it isn't understood, can give rise to very poor outcomes, really, in general for the profession. The best use of data is where feedback stimulates data collection, and patients and surgeons actively want to be involved in it. And then there needs to be a robust interpretation system. There is quite a problem with getting our registry data published in some spheres because of publication bias and the missing data issues that I mentioned before. And it is complex and needs to be put into context and interpreted by clinicians, and then that needs to be explained to insurers and government. And transparency has to work both ways, both for the surgeons who are being studied and those who wish to criticize them. And ultimately, we should all be using this data as a light at the end of the tunnel. And I think that you're off to a great start with your registry. Thank you very much for the opportunity to speak this evening, and hopefully we have a little time for some questions now. Thank you very much.
Mike, thank you so much for that. Even more grateful that you're on holiday and you've interrupted your holiday to do this. So I'm a fisherman myself, so I do appreciate the sacrifice you've made there. What a lovely fish that you caught today.
It was so nice that I thought I'd better let it go and grow up.
Very good. I mean, fantastic insight into your experiences with the Ligament Registry. I suppose you've given us a flavour there for some of the advantages and some of the challenges. If you were to rank your sort of current challenges, I suppose, how would you rank those at the moment? Is it engagement of surgeons? Is it engagement of patients?
So I think unfortunately, the pandemic's had an incredibly negative effect on our industry as a whole in Europe, Asia, Japan. The States, the surgeons there haven't stopped working, and in fact have been busier. So the ICRS, the International Cartilage Repair Society, quite a few of the board are Americans and just didn't understand why everybody else was struggling to find data to input. Subsequent to that, then we have a funding issue, because industry not making money means that industry will look for things to lose first. And so genuinely, I think it is absolutely fantastic that you as a society are funding this, because you maintain absolute integrity then, and you are not at the whim of pandemics or commercial issues. So I think that at the moment would be my main problem, but it's also now we're coming out the other side of it, and companies are contacting us to fund us again. I think then after that, it would be trying to identify the smallest data set that you can get meaningful data from. So the National Joint Registry, the Arthroplasty Registry, is one side of A4, but it's really asking management questions, and it doesn't really deliver on a clinical setting. So that is a tension, that we have data that's sufficiently detailed to be meaningful versus data that people are willing to input, so that you reduce missing data. But there are techniques of interpolation that are now fairly well validated, where if there is missing data, you can make sensible judgments about the areas that weren't filled in based upon the responses from others. And I think as time goes on, there is quite a push for the medical profession to measure its outcome, and there's been a few well-publicised surgeons doing things that they shouldn't have been doing, which actually has been a positive drive for engagement by many of the stakeholders that I listed. So I think the future is knowing what we're doing. The future is it's going to get better and better. And I think as we get more experience of how to deal with big data, and maybe apply some of the artificial learning that was mentioned by the previous speaker, we'll begin to see patterns that that we can't comprehend ourselves, but with artificial intelligence, there's you can't have big data without collecting it. So, you know, it's an exciting thing to be involved in. I think it's an important thing to be involved in. And I think that it's been a great honour to listen to what you've been doing this evening, and you've really set things up in a great way, I think.
Well, thanks, Mike. I was interested that your own dogs have had cruciate surgery, and so you've had the benefit of veterinary care, or they've had the benefit of veterinary care. I'd just like to reciprocate and say I've had the benefit of orthopaedic surgery at Aintree University Hospital. I'm reaching to my left clavicle here, like the plate and screws I can feel here. But one of your colleagues looked after me very well. I guess I was interested in your comment about women suffering contralateral ACL rupture, because it's well recognised in dogs that dogs will often suffer bilateral injury, and it tends to be breed related. And there's quite a few studies now looking at the genetics of that in dogs, because we deal with inbred populations where actually the genetic, the power in genetic studies is quite high. So what's your view on that bilateral issue in women?
So there's been, again, having identified it as an issue, they were able to focus upon it. And actually, when they studied kinematically what was going on, abnormal landing posture was far higher in young collegiate female athletes than it was in males. And so I worked with a group years ago when we started seeing these things being recognized, to put together a bunch of exercises for proprioception, landing strategies, and then bigger groups got involved. And the FIFA 11 Plus now is a program that's run out all over the world and has significantly reduced the incidence by teaching females to land with a bent knee rather than hyperextended. And they by the use of about 5 minutes worth of warm-up about 3 times a week, just involving that in their routine warm-ups, they've been able to reduce the incidence. And so there's some theories around increased laxity of ligaments, potentially related to the menstrual cycle. They certainly got, females on average would have a smaller knee and a smaller notch size. And that, again, is an increased risk for ligament rupture. And so, you know, I mean, I think there's a whole bunch of different things coming together, that in the States and in some of the Scandinavian countries, there's a far higher rate of female ACLs. But in the UK, female sports participation, whilst it's growing, isn't anything like male participation. So our national figures are very different to those in the States, where I think there's so many kids that want to get paid to go through college that they're all far more active than maybe our own teenagers are. But it's very interesting. And if you've not measured the data, you're not aware of it, you can't look to see it. When you see it, you do something and you can make a difference. How good is that? You know, and it doesn't involve a knife. So that,
yeah, absolutely. It's really interesting. We could talk all night, Mike. We'll have to get you back to our British Veterinary Orthopaedic Association and talk cruciates. So what I'd like to do, if I can, the remaining speakers, if I could ask you to put your videos back on so that we could. I think Duncan might still be with us, I'm not sure. Yeah, anyone else? Mark is here. Just to wrap up, really, there are a couple of questions in the Q&A. There's a question here from Angie Kingman. Thank you, Angie, for your help with the registry. I know you're very involved with PROMs. Do you see an opportunity for learning by long-term owner-reported outcomes in dogs you may or may not be seeing anyway? So I guess, Mark, this relates to the long-term nature of the registry, which I guess is a huge weakness in our data thus far, isn't it? Because most of our data comes out of referral surgeons who sign off after 6 months. Yeah,
absolutely. The answer is we just don't know. And I think that will be a challenge, you know, as Mike said, you know, encouraging people to continue submitting data over the long term. Angie's been really helpful to me, and so Angie, for those of you who don't know her, is a sort of outcomes coordinator up in the northeast, and works with the NHS trust up there, basically cajoling orthopaedic surgeons into getting their patients to fill out all these outcome measures. Probably Mike's nightmare. I think actually all the surgeons you see working with Angie are very grateful for her help. But one of the things she said to me at the very start was, one of the keys to engagement long term is saying to people, you know, I can't phone you up every week and ask how you're doing, or phone up you every week and ask how your dog's doing. But if you continue to fill out these outcome measures, I'll see what your scores are. And if we see you're not doing so well, that'll alert us to the potential for a problem. So sort of putting it back onto owners that they can be involved in monitoring their patients' outcomes. And hopefully that's one way we can engage long term and get some lifelong data from these patients.
Maybe this is another one. Thanks, Mark. Another one maybe for you. If you can maybe mute yourself. This is a question from a delegate from the States. First of all, she said, this is amazing work and a great resource. When will it come to the States? Maybe part of that question. But a really good question for immediate answer is there a template in a single document that contains all the info that the website will need when you upload a case, so that when you're interacting with a case in the clinic, you can make sure you've got all the data?
It's a really good idea that there isn't currently a template. I mean, I think we've tried to make it as simple and straightforward as possible, so it sort of asks you the questions in a logical way, and there's not that much you need to put in from a history that that you might not know. And then the surgical report, I was sort of reflecting on our surgical reports with what Mike was saying, that we had an advisory group that's developed quite a comprehensive range of data. I think one of the problems that we have is because we don't really have any registries like this already, we don't have any experience of knowing what's useful to collect or not. I'm sure there's loads of stuff in there that actually we don't need, but we felt a bit at the start, well, let's try and collect what we can, and over time, see what people do and don't fill out. And again, one of the things that Angie said to me was, you might have some surgeons who want to record the length of every single screw and surgeons that don't. I think what we'll do long term is make some fields mandatory and the others optional. And Mike, you had a point on that as well.
Yeah, I think one way of interpreting that question is, do we have what's called a schema for the data? And there will be that. So it sounds like there aren't other registries for you to import data from, but having the schema for the ICRS registry has allowed us to continue to import data from historical databases with appropriate ethical approval. And so if you asked Amplitude for the schema for your data collection, then that's quite valuable when, if alternative groups wish to join in, they can include your core data set and then add on any bolt-ons that they feel is necessary. So that's the terminology that the company that you're working with would want to hear for one interpretation of that question.
Thanks, Mike. That's really helpful.
Duncan, you've led multiple prospective studies in your research group. What tips do you have for, in this respect? Do you have any practical tips, I suppose, in the clinic for making sure you capture the data that you want?
That's a really good question. I mean, I think it kind of, that speaks a little bit to the question that came up, just understanding what data are needed, getting everyone familiar with that so that they, as they're seeing these cases, that's on their mind, that they're thinking about either asking those questions or collecting that information. I think a lot of it comes down to building a team spirit here. And that team is within the clinic. It goes out to owners, engaging owners, and believing in owners. You have to, in order to engage them, they have to feel part, and they should feel part of the team here that's collecting this information. And so certainly, one thing I found in my little clinical studies is keep that team spirit up, keep everyone engaged, make sure everyone knows that they are an important player in collecting this information.
And I guess, given this is a long-term project, as there's churn in the clinic, you've got to set dates to kind of re-energize the team and re-inform the team as new members join and experienced members depart. And I guess you experience that too.
Yes, absolutely. And I think, one way of doing that is generally people like new information, they like knowledge, they like to learn. And so, having, providing opportunities for the team to come together and learn and understand why they're doing this, as opposed to just, this is what you need to do. Why are you doing it and what's the benefit? Mike?
I think managing your surgeon engagement would be assisted by holding maybe a side meeting when you've got your national meeting. And we would do that the night before the British Knee Surgery meeting at the BOA. And all the users then have an opportunity to suggest things that they might like introduced. And instead of that being a constant flow, which is almost impossible to manage, you pulse it. You can then look through, prioritize the things that you're going to adopt, prioritize those that you might drop, and then feed back so that everybody feels that engagement that Duncan's mentioning. And then it really is a team effort and everybody's engaged.
Yeah, that's a good point, Mark.
One thing that I sort of realised quite quickly just working with the advisory group is, and the steering group, is how day to day we all work differently. So our workflows and patterns are not the same. And I've learned testing this, how I can get owners to use it. I know where to drop it into my consultation to discuss it with them, but it's going to be different for everybody. And I'd encourage anyone who starts using the registry, if you've got a nice little trick you use with owners or something that you think helps, please share it. We've got a top tips section on the website, which is currently blank, but there's a place there where you can say, you know, what I find helpful with owners is, or I find it helpful if we get our admin team to do this. So we want to learn, all of us together, the tips and ways we can encourage engagement.
Mike, yeah, carry on.
So another thing that may have been mentioned already is for the people that aren't quite so familiar with it, it's quite a long and difficult conversation. You can circumvent that by having business cards with a QR code on, and you know, your examination identifies what we call a positive Ligament test. That draw, it's an ACL patient or dog, and please have a look at this. I think you'll find it interesting. And then that devolves responsibility to the patient. They go off, have a look. They're then consented as they come through the system. And I would imagine they've set that up for you in the same way. But the business card on the desk is sat there as a visual reminder to the individual practitioner as well. Oh, yeah, it's an ACL. Here's something. Have they suggested that for you with Amplitude, or are you considering that type of an approach?
Yeah, we discussed that, and it's certainly one of the ideas we had going forwards from a publicity point of view, to exactly for that reason, to act as a prompt. So it's interesting that you've said that as well, and that's certainly something I think we can look to long term. Yeah, it's a good tip. The QR codes are really nice shortcut, aren't they, to get patients onto the information. Let me see. I think this might be, there's a question from Paula asking about comparative studies in human medicine, but Mike, I think you did a great job of describing some of those interesting hypotheses and findings in human surgery, and we'll definitely have to get you back to speak at a vet meeting. So hopefully, Paula, that Mike has answered some of your questions. And there was another, maybe this is the last one really, I suppose, which is about, is there expertise on the group to look at the underlying factors around the risk of cruciate rupture in dogs, Mark? I know you've got an epidemiologist involved, so maybe you could expand on that. Yeah, absolutely. So we're lucky to have Professor Tim Parkin involved from University of Bristol, and he's been a great guide with what we do with the data and how we structure it long term. We've got some sort of underlying data in there, sort of mainly demographic data, breed, sex, age, etc., etc. And all those factors can be analysed going forward. I think we have to see what we get with the data long term. So we'll see where we go with that. We're certainly trying to collect what we can, and yeah, can all be analysed going forwards. Great. Well, I think at that point we will wrap up. I guess it remains for me to say thank you to all of our speakers. To Mike, thank you for breaking into your holiday, and we were running late too, and you've given us a huge amount of information. We really appreciate that. Your expertise and your time, so thank you. To Duncan there in Raleigh, North Carolina, thank you, Duncan. Good to see you in 2 dimensions, hopefully in 3 dimensions at some point. Thanks for your expertise and insights this evening. To Stanley Kim, who's had to leave us because he had to go off and do clinics. It was 9 o'clock in the morning there, and he's having to do a day's work, so thank you to him. And to Mark, obviously giving us information about the mechanics of the registry and how it will work. And also to Amanda and all of the RCVS knowledge team who worked tirelessly in the background to bring this to fruition. I have to say, looking at the stats here, most of the webinars I ever do, most participants have left after 15 minutes, but we've clung on to the vast majority of participants tonight in what's been a long session. So that's testament to the great speakers that we've had this evening, and we really appreciate it, and we hope this is a real successful launch for the registry. So thanks everyone, thanks for attending, thanks for your questions. You've got links or emails that Mark gave you where you can fire in extra questions if you've got them.
Maybe, as Mike said, we should pulse those at some point. That's a good tip. And thanks everyone for attending, and please get involved, and we look forward to your contributions. Thanks very much.
And thanks to John for chairing.